Hello, and thank you for taking the time to watch this video. We are excited to share with you the journey of a cross-sector partnership to align efforts for advancing health equity. You will hear directly from partnership organizations and learn more about their powerful story. First, the team at NACHC and AAPCHO would like to acknowledge the Robert Wood Johnson Foundation for their generous support of our program and efforts to showcase the impact of community health centers and cross-sector partners. My name is Nalani Tarrant, and I'm part of the NACHC and AAPCHO team that worked on this program funded by RWJF. I had the privilege of working with Nasson Health Care and Your Community Action Corporation, and would like to briefly provide some background information before you hear from them. I'd like to take a moment to provide context and share our guiding why in developing this program. Our country is at a critical juncture with the global pandemic, racial reckoning, and economic downturn, calculating the need to identify policies and structures that create health disparities across our communities. It has long been known that racial and ethnic groups, as well as special populations, are most impacted by structural racism and systemic discrimination. As communities respond to and rebuild from COVID-19, there is an opportunity before us to drive systems-level transformation to ensure all communities are healthy and thriving. In fall of 2020, our team recognized the challenging moment community health centers and cross-sector partners were in as they cared for their communities during the pandemic. We wanted to support the work they were already doing and meet them where they were at in their respective journeys. As a result, we wanted to use the design sprint framework to do just that. A design sprint cohort is a short burst of facilitated training and technical assistance with peer-to-peer learning focused on cross-sector collaboration and creative problem solving. Moreover, the design sprints created the space and structure to facilitate cross-sector collaboration, data sharing and analysis, gap identification and health equity, and continuous process improvement. By leveraging SDOH data, design sprints can foster strategic alignment between health centers and their health and human service counterparts, including community-based organizations, public health departments, and other social service providers. Through a human-centered design thinking approach, NACHC and AAPCHO created a space to catalyze local community partnerships that can use data-driven strategies to manage complex patient care, prioritize population health needs, and collaborate on upstream courses of action that improve and sustain health equity. Our design sprint used RWJF's Theory of Change Alignment Framework, which has 4 pillars centered on shared purpose, data, governance, and finance. The framework also acknowledges that community voices, equity, power dynamics, and trust greatly impact and inform cross-sector alignment. During the design sprint cohorts, 4 cross-sector community teams were selected to participate in 4 different cohorts. Each cohort was comprised of a 3-month-long design sprint process, including sharing of best practices and training with technical assistance. Each sprint focused on building partnerships and stakeholder-led strategies consistent with the domains of RWJF's Theory of Change Alignment Framework. Now, it is my pleasure to introduce the team that I worked with during cohort 2, which focused on data. How might we create a shared data or use data collaboratively to address SDOH needs? Welcome, Marty and Megan.
Thank you. So, my name is Marty Sable. I'm the director of Nasson Health Care, which is a community health center and a division of York County Community Action Corporation. York County Community Action is one of the original community action agencies. We are roughly 55 years old, founded in the mid-60s as part of the War on Poverty under Lyndon Johnson's presidency. Nasson Health Care has its roots as a special populations community health center. We opened in 2005 to serve York County residents who are either experiencing homelessness or living in or near public housing facilities. With Affordable Care Act support in 2012, we were able to broaden our focus to serve the entire community regardless of housing status. That said, our patient population is overwhelmingly living with very low incomes and otherwise dealing with a lot of complex social issues. Back probably 10, 12 years ago, we began reporting clinical metrics as part of several initiatives that were geared toward improving clinical quality metrics in community health centers, and we eventually became part of an accountable care organization. And we couldn't help noticing that our clinical metrics were just substantially lower than our sister health centers in Maine. And that got us thinking that there's more to this than we are appreciating right now, and did some research into social determinants of health, and that really sparked our interest in this area of work. So yeah, fast forward 2018, 2019 or so, once the PRAPARE tool, once NACC made known their interest in working in developing and implementing the PRAPARE tool, we were on board immediately. We have begun, we'll back up just a second. We are a federally qualified health center. We have primary care, behavioral health, dental services, as well as care management services for a patient panel of roughly 8,500 active patients. So yeah, we're very interested in understanding better and being able to take action to address these social determinants of health. We have sort of phased in use of the PRAPARE tool, looking primarily at food, housing, and transportation as the most actionable and most prominent risk factors that we felt our patients experienced. And we have now adopted the entire, we now use the entire tool in all of our disciplines. Change is difficult, and we're now running at about 50% of patients being routinely screened at least once a year for, again, all of the PRAPARE risk factors. I guess I'll turn it over to Megan at this point to talk through, well, one other point, and that is, in addition to screening for social determinants of health, we actually take the step of having our medical, dental, and behavioral health providers look at positive responses to the PRAPARE screening tool and actually evaluate and get to a diagnosis, an ICD-10 code that they actually add to the patient's problem list and include in their encounter to be uploaded with all of the other ICD-10, all the other problems that were addressed in the visit. So once the diagnosis is made, the provider then has several options in terms of managing that diagnosis. One is basically to acknowledge that the problem is there, maybe provide some printed materials, some resources in our community that might be helpful, right on through referral, active referral to case managers elsewhere in our agency who then follow up with patients and engage in some social work interventions. Megan.
Okay, thank you. Nalani, you can go to the next slide, please. So as Nalani was sharing, we participated in the design sprint focused on data. And one of the things I just wanted to share is a little bit of background information around how we even landed on our design sprint idea, because as Marty was just sharing, we have an existing relationship between York County Community Action and Nasson Health Care that was already in existence. But the truth is, until we were implementing the PRAPARE tool, and even still, we're having to do a lot of work around this, is we haven't integrated the social services and the health side of things really effectively, because it's really challenging. But we were already working together. And so I just wanted to share a little bit. so my role is, I actually used to be a director on our social service side of things at York County Community Action. And now my role is around integration of our services. So we decided this was, we probably started this a little over a year ago, where we wanted to focus on looking at data between both our social service side of the agency and our health side, Nasson Health Care. And so we really wanted to, as you can see at York County Community Action, we wanted to have it so that all families being served by any program across the agency would achieve what we call well-being and move just beyond the results of a particular program. And so we were focused on social determinants of health because we really believe that that was going to move families holistically towards well-being, and a recognition that to achieve well-being, that includes healthcare and includes housing and financial well-being and all these other things, right? So we wanted to really integrate services to achieve that across all the different services, both social and health related. And so we wanted to look big picture around like, well, who's going to be impacted by this? How are we going to do it? And so we acknowledge that, you know, patients essentially could be really engaged at the health center, but not necessarily having social needs met. On the social side of things, we had coaches work, you know, or case managers working with families, but that they weren't always connecting all the dots to everything. And we needed people to understand our families more broadly and to connect to services across, like I said, both health and social. And so we were focusing on internal referral processes. We wanted to have data sharing, and then we also wanted to have some shared performance measures. So that just kind of gives you a little bit around like that was really sort of the foundation of the partnership that was existing between the social side and the health side. So you can move forward, Nalani. So we wanted to have agency-wide data for both reporting purposes and frontline staff usage. We're still working on that. It doesn't exist at this point. Right now, it's a lot of running reports and then sharing information. But we have identified technology that we're trying to implement and utilize to support this process. And so we have what is known as Community Action Data Store that's going to help us support data sharing across programs. We also have databases on the social side, and then we also have our next gen software on the health side, and then using technology to support referrals as well, so that we can be tracking everything in our systems. And so technology is a big part of the workflow and the process of, and making sure that we know that we're actually having success around this work. You can continue, Nalani. So some considerations was that we needed to think about how we were going to fund this technology and the staffing. We needed to have partners who really understand this vision of our work. And I mean, even from like our vendors, like we've been working really closely with our vendors to provide the reports and the data so they really understand what we're trying to do to measure SDOH work. And we have been, you know, Marty knows this, we have so many work plans and visions and goals around all these things, and a team that reviews that regularly. And then having commitment to this work from from organizational standpoint. So leadership across the board, all invested and committed to this is really important. We've learned that this takes a lot of time. It's taking us so much longer than we ever imagined, that it's also about change management. It's not just about having the technology to make a referral. So you can have all the workflows set up in the world. They can click buttons, make referrals. They can measure, you know, have diagnoses and all of these things. But at the end of the day, you know, we need to have trust between people. We need to have relationships. I mean, these things matter in order for this to be effective. And then also having a person that can really help lead the effort was another thing that we found to be important, which is partly why my role changed in the organization so I could better support this type of work moving forward. So with that, I actually wanted to go a little bit more deeply into what Marty was outlining in terms of like, what does this actually look like? Because I know I just shared sort of very high level stuff with everybody, but what does this actually mean on the ground? So Nalani, we can actually turn to the Prezi now. So when we started, so our design sprint, our sort of goal with our design sprint, as you can see here, was that Nasson Health Care and York County Community Action Corporation need to increase successful referrals addressing food insecurity to improve food security, resulting in improved health. Patients may be unmotivated and or workflows are not being followed or understood, so less referrals are being made. So when we joined this design sprint, you can see how we had sort of this big vision of what we wanted to accomplish, and we were getting really stuck. So the design sprint was really wonderful and beneficial for us to participate in because we focused in. Like we said, let's look at food insecurity, let's look at this particular area and our workflow, and let's actually measure and implement some of our existing systems that we have been using to really understand what's going on and make some changes and improvements and adapt. And so this was really helpful for us to really kind of laser focus in an area and see what we could learn. So our process is essentially step one, the PRAPARE assessment. So what we do is patients come in, they are going to go through the PRAPARE assessment. We, from our design sprint plan, we said that we wanted to develop and run regular reports of responses and understand the breakout of the needs so we could get a sense of, well, how many needs are for food insecurity versus housing versus other areas. And then we also wanted to speak with other FQHCs to see if they're seeing similar results to what we were seeing. So step two, which by the way, I should mention, we did actually develop a better report to access PRAPARE data. That was part of the work behind our design sprint, was that within our system, there was not a very strong PRAPARE report for us. So that was something that came out of our design sprint, was the development of a better reporting system for data analysis. So step two is after the patient does the PRAPARE screening, they obviously come in for their appointment. The provider will assess and then diagnose based on the encounter that they're having with the patient. And so then what happens is that we would want to develop and run regular reports of our diagnoses based on what the providers are diagnosing. So we will actually diagnose food insecurity or housing insecurity or other things of that nature. And again, we also wanted to speak with other FQHCs to determine if they're seeing similar results. So as you can see here, we just ran it from a short time period. This one was just over like a 3-week period. And you can see that during that 3-week period, we had 83.33% of our diagnoses were around housing insecurity. And then we only had about a little over 3% for food insecurity. We also, you can see here, that other pie chart, we also broke it out to take a peek at who is actually making diagnoses. And so these are our providers. And so we actually were just kind of curious to see how our providers were doing in terms of making SDOH diagnoses, because it is, it's still a learning process for our providers to actually go through this and make diagnoses on social determinants of health. And so that's part of our sort of measurement of process as well, as to see how providers are doing in that. So after the diagnosis, the third step is that the provider would determine if a referral should be made. And so we then also wanted to run reports around our referrals and to see, how many referrals we're making, what are they for, again, wanting to speak to other FQHCs to see if we're seeing similar results. We recognized very quickly that we needed to develop trust between providers and the social service provider. And so we started meetings around that, and then a clarity of workflow and expectations. And so you can see here a comparison of weeks. The provider sends a referral through a referral specialist to York County Community Action. So you can see, the week of May 3rd, basically of the diagnoses that were made, 25% resulted in a referral. And then Nalani, if you click on the week of, yeah, there we go. And then you can see that week there were 40%. So just because there's a diagnosis doesn't mean that there needs to be a referral. As Marty said, it could be simply like providing some information about a local food pantry or something of that nature, if that was the appropriate intervention versus a referral. And so that's why you might be wondering why they aren't all referrals. It is because of that situation. So then after that, on the social service side, so step 4 is that we call them outreach workers. That it's their social service provider will assess the social needs more deeply and provide resource navigation, eligibility determination. They basically connect our patients to a wide array of services, and will actually create a plan with the patient around helping them address their social determinant of health need. And then lastly, the final step in our process is that consult notes go back to Nasson, to the healthcare provider from our social service provider, indicating the intervention results and next steps. And so this here shows you what the result was. So what this means is you can see housing is 0. It doesn't mean that there hasn't been work done, but what it's suggesting, or what it's telling us, is that we had many referrals for housing, but none of them resulted in the patient getting housed, because housing is very limited in our area. Instead, what's happening is our social service provider is filling out housing applications and doing all of that type of work with the patients. And just in that 2-week time or 3-week time period that I ran the report, they hadn't secured housing in such a short time frame for those patients, but they are actively working with the patients in an ongoing way to get them housed long term. So in the short term, they haven't received the housing, versus, not surprisingly, for those referrals that were for food, pretty much all of them were able to access food almost immediately. And for transportation, you can see it was they were able to meet the transportation needs of about half of those that were referred. Again, it could just be because of certain circumstances and what resources and the location of the patient as well, and what's available where they live are all factors in the results of these referrals. So we have a lot that we're still figuring out. And so the summary is basically the design sprint really helped us develop our work plan. It allows us to really look at specifics in how our workflow is. It allows us to review our existing data to inform future direction, but we definitely have a lot more work to do around building some stronger workflows and trust. But it all has led us to a greater focus, and we're going to continue to hone in on our efforts and continue to improve everything as we move forward. And so, Marty, I don't know if there's anything else you want to share at this point.
Yeah, I mean, just 2 thoughts. One, while we may not be able to address all social risk factors, even in the long term, it's really important, as we see it, to have solid data that can drive public policy decisions that at the community level or the regional level start to address these problems in an effective way. Transportation's tough in a rural area. Housing is tough in an area that is where it's tough everywhere, but particularly in southern Maine, it seems. But yeah, again, being able to risk adjust the patient panel and have solid data that can drive public policy decisions seems like a noble effort in itself. And the other point is, here in Maine, we have how many, 8 or 10 community action agencies and 20 federally qualified health centers. We basically cover the entire state in terms of our service areas, and suspect that that's the case nationally. There are 1,400 or so community health centers, maybe 1,000 community action agencies, and all potentially could have these kinds of relationships or begin developing them. Community action agencies generally have some level of social services available to their communities, and FQHCs are in an ideal position to screen and identify needs among their patient populations. So it seems like a really good fit in many ways.
Thank you so much, Marty and Megan, for taking the time to share your story. You all did incredible work, and we appreciate your sharing your learnings with others. We'd like to thank RWJF again for their generous support of our program. And for more information, or if you have any questions, please feel free to email us at prapare@nacc.org. Be sure to stay connected and join our listserv so you can stay updated on new resources and tools related to social determinants of health and advancing health equity. Thanks, and take care.